Good morning, everyone. Welcome you all for today's session. Being the first session in 2025, I would like to take this opportunity to welcome you all. And I know this is a very short notice that we shared with you the today's event actually. So there are technical issues, and even we registered earlier, and the session was not approved till today. So hopefully, thanks. We need to also thank IAPC for taking their extra step to fix the issue and approving the session at the last moment. Otherwise, we would have been planned to cancel the today's session. But in spite being the first month, we thought let us have a one session so that it will be more informative. And I know it's a very crucial time. Many of you will be renewing your CEUs and renewing your membership as well, right? So you need your CEUs as well. So we thought this session will be more helpful for you. Also, being the first selection of the topic, right? As you know, we have a lot of challenges when we review our documentation, right? So, even when you are part of the Tasnif audit as well, you can see there are certain scores given for the physician queries, right? So how to manage the query and how we can support the team actually. So that will be more crucial, and that topic will be very much that activity will be very much crucial for a coder actually, right? As in a day-to-day life, we need that query process. So nowadays you can see there are many physicians will respond, and sometimes they will not respond actually. Also, we would have seen in our practice, right? Some of our coder, if they query a physician, we can see they will be replying very soon actually. Physicians will be replying, or they will be more interested to reply that query is very faster. Sometimes when we send that queries, we will be facing challenges, and we can see there will be a delay in reply as well, or sometimes they will be very much reluctant to reply for that queries, right? So uh, maybe there may the way they query the physicians, right? It is the one causing the difference. Sometimes some physicians, they will not like a very lengthy email, or somebody they want a more detailed email. So we need to know what is the correct way to send queries, right? So that is why we thought, okay, this query process will be a very important step, so that at the beginning of the year, if you know these type of principles, it will be helping you all in the upcoming years as well, right? So that's why we thought, okay, this topic will be a very good topic. And in order when we come to the selection of the topic, it's very important to introduce the speaker, right? So during the selection of the speaker, right, I think you would have known in many of the chapters this speaker actually, right? Miss Mahalakshmi Vaithillingam, right? She is not only presenting in India, because she is basically from Chennai, and she is not only presenting for Indian chapters or local chapter in Chennai only. She is a well-known speaker, and with lot of experience, and basically she is having a physical therapy degree, and also she is having CPC, COC, AHM, and she also have the quality certification LSSGB, right? And more than 18 years of experience in medical coding, with a lot of experience, and even though if she has experience, she has very good teaching skills. She is one of the international speaker. You would have find her in AAPC conferences, and also nowadays she is very busy. Even she is presenting in US chapters as well actually. So there are a lot of efforts she is taking, right? The time will be a lot of difference will be there. For example, if you want to take a session in US, you need to be waking up early morning in Indian time actually, right? So she is with lot of dedication and a lot of interest, she is doing that extra miles to uh, guide the coders and for to get their correct knowledge and input actually. So when we come across for our chapter as well, we feel very much happy to have her as a speaker and to share her experience, to share her input to us actually. Okay, so that's why we selected Mahalakshmi, and I hope she has her mic access as well. And we would like to welcome on behalf of all of you to be as a speaker today. Mahalakshmi, the stage is yours. Please go ahead.
Thank you very much for the introduction, APC Local Chapter Abu Dhabi. Hope I'm
We can't.
audible.
Your mic is not audible, Mahalakshmi. You're unmute, but we can't hear you.
Hope am I audible now? Hope am I audible now?
Can you disconnect and join again so that we can try?
No, members are saying that they can hear me.
Still not audible, Mahalakshmi. Once again.
Yeah, sure. Thank you, members, for thank you for the introduction, chapter Abu Dhabi officer. Thank you very much. So, hi everyone. Very good morning. I would like to warmly welcome you all to this chapter meeting and thank you for taking time to join my session. I am aware that many of us are aware of the coding query practice. So, today's session will help you as a refresher and this will add value in our day to day coding process. So quickly, I will go ahead and share my screen. Please acknowledge when the screen is visible for you. Yeah. Is the screen visible, Shay? Okay, yeah. Yeah. So I welcome you all to the session. So we are going to discuss about guidelines to manage complaint query practice. So I am Mahalakshmi Vaithillingam, physiotherapist with the certifications COC, CPC, Healthcare Management Accreditation Certificate, Six Sigma Certificate, and recently AA Medical Coder Certificate. So, before starting the session, I start with an icebreaker. So do you all know about the importance of today? The special about today? It is National Tourism Day 2025. So India celebrates National Tourism Day on January 25th to promote responsible, sustainable and accessible tourism. 2025 theme is Tourism for Inclusive Growth. The government collaborates with the various stakeholders to boost tourism and create jobs while preserving cultural heritage. Events include workshops, photo contests, virtual tours, and guided walks to encourage sustainable practices in the tourism industry. So go ahead and research on it more. And if you have plans to visit Chennai, I am your friend here in Chennai to help you walk through on the interesting places. So without further delay, I will take you to the session. Medical coders come from all walks of their life, right? Some individuals start their coding careers by transitioning from clinical roles in healthcare, while others are recent high school graduates. We do not focus on an individual's background or personality type when determining what makes a good coder. However, we do recognize certain traits that align well with the profession. Are you curious? Do you like to learn new things? No matter how long you have been a coder, you will encounter something new on a regular basis. Hope you all agree with me. Detail oriented. Do you have an eye for subtlety? One word in a clinician's documentation can mean the difference between the right code and the almost right code. Agree? Organized. Are you frequently late for appointments? Is your word cluttered? Coders must be able to manage time and space to avoid errors and meet deadlines. Ethical. How are you with the secrets? You will need to respect patient privacy, PHI, and actively protect patient data. Analytical. Can you, with the connecting the dots? Good critical thinking skills help when pursuing guidelines to choose appropriate codes. Important medical coding skills. Medical coding involves abstracting information from the medical record. Medical coders need working knowledge of anatomy and medical terminology. We also need to know how to report codes appropriately in a highly regulated industry. So the industry specific skills, ICD-10-CM, CPT, HIPICS, medical terminology, anatomy, pathophysiology, revenue cycle management, healthcare regulations. The professional skills, communication, critical thinking, problem solving, time management, attention to detail, research, organization, and of course, computer literacy. So, the agenda of today's presentation: what is a query? Why to query? What to query? Role of prior encounters in queries. Clinical indicators. Who is queried? Oh, yeah, just a minute. Thank you for telling me this. Let me check what is it. Yeah, okay. Sheikh, what I will do, I will send the presentation to you. Is it possible to share it from your end? Okay. One screen only. One second. Yeah. I have given window only. Yeah. Yes, yes. Is it visible now, Shay? Yeah. Okay. Is it moving now? Okay. I'm extremely sorry, members. Don't know what is the issue. I will just take you through the slides, what I was talking on. Yeah. Thank you very much for your patience on this. So we were seeing the guidelines to manage complaint query practice and the introduction about me and about the disclaimer. And I just took the presentation on today's special event and special about today. And yeah, I started here the role of a medical coder in the medical coding field. I have explained this and the important medical coding skills we need to have in the industry specific skills and the professional skills. And today is the agenda of the presentation. So are you all seeing my the current slide? Okay. Thank you for this confirmation. So yeah, I will proceed with it. So we are discussing what is a query, why to query, what to query, role of prior encounters in queries, clinical indicators, who is queried, how to query, query policies and procedures, query retention policy, escalation policy, and the best practices. So who should follow these guidelines? With the evolution of reimbursement methodologies, the focus on severity of illness, medical necessity, risk adjustment, value-based measures, specific documentation related to diagnosis capture, acuity, and clinical validity have become more important. The need for clear and accurate documentation and how it is translated into claims data impacts healthcare roles such as case management, quality management professionals, infection control clinicians, and others. In support of organizational objectives, query professionals actively engaging in educating providers to document in clinical standards. That is where we got the CDI in place. Examples of non-compliant queries includes directing a provider to document a diagnosis that is not clinically supported, adding a non-reportable diagnosis, or encouraging a provider to neutralize documentation suggestive of a post-surgical complications. Hope you are all with me. What is a query? A query is a communication tool or process used to clarify documentation in the health record for documentation integrity and accurate code assignment for an individual encounter in any healthcare setting. The synonyms are for the query includes clarification, clinical clarification, documentation clarification. The documentation queries are used by coding professionals, CDA professionals, and all professionals responsible for documentation clarification. All queries, including verbal queries, should demonstrate compliance with all query requirements to validate the essence of the query. Regardless of how the query is communicated, it needs to meet all of the following criteria. Be clear and concise. Contain clinical indicators from the health record. Present only the facts identifying why the clarification is required. Be compliant with the practices outlined. never include impact on reimbursement or quality measures. As query templates are now increasingly embedded in the electronic health record or workflow software, query professionals must ensure relevant clinical indicators specific to the patient, as cited within the health record, are applied and referenced appropriately. Additionally, the choices provided as part of the query must reflect reasonable conclusions specific to the clinical scenario of the individual patient. Why to query? Queries are utilized to support the ability to accurately assign a code and can be initiated by either coding or CDA professionals. Queries may be necessary in the following instance: to support documentation of medical diagnosis or conditions that are clinically evident and meet the requirements, but without the corresponding diagnosis or condition stated. To resolve conflicting documentation between the attending provider and the other treating providers. To clarify the reason for inpatient admission. To seek clarification when it appears a documented diagnosis is not clinically supported. To establish a diagnostic cause and effect relationship between medical conditions. To establish the acuity or specificity of a documented diagnosis to avoid reporting a default or unspecified code. To establish the relevance of a condition documented as a history of, to determine if the condition is active and not resolved. To support appropriate present on admission indicator assignment. To clarify if a diagnosis is ruled out. To clarify the objective and extent of a procedure. A health record may contain documentation authored by a variety of healthcare professionals, right? Increasingly, the electronic health record may also contain information whose origin and accuracy cannot always be easily verified. It is the scope of querying professionals and CDA professionals to manage the provider documentation practice. When coding and CDA professionals identify that the health record fails to meet one of the following criteria identified below, and after education and query efforts have been exhausted, it should be reported to the appropriate facility under organizational authority. What to query? Legibility, completeness, clarity, consistency, reliability, timelines. Facilities and organizations are encouraged to have robust guidelines in place that define the contents of the health record and outline documentation expectations, including the use of copy and paste functionality, which happens right now, right? Automatically populated fields, example, problem list, diagnostic results, etc., and document templates that are included within the health record. The focus of coding professionals is to review the health record to ensure clear, high quality clinical documentation. Ambiguous documentation fails to reflect the provider's intent, impacts the clinical scenario, example, complications, quality of care issues, the accuracy of code assignment, and the ability to assign a code. It is important to note that code accuracy is not the same as a code specificity. Hope you are all be with me. In a situation when multiple queries are required regarding the same set of clinical indicators or ambiguous documentation, querying professionals may need to utilize verbal queries to discuss these complex circumstances. For example, if both a diagnosis and additional specificity must be established for accurate code assignment, the presence of CHF and its type, a verbal query may be necessary or two separate written queries. Trying to obtain too much information in one query may result in a non-compliant query, right? There may be times when a second query is needed to obtain further clarification of a previously answered query as additional information becomes available or as the clinical picture evolves. However, it is considered non-compliant to continue asking the same query to the same or multiple providers until a desired response is received. Agree? What to query? The objective of a query is to ensure the reported diagnosis and procedures derived from the health record documentation accurately reflect the patient's episode of care. Complaint query practice should follow these tenets. Queries must be accompanied by clinical indicators that are specific to the patient and episode of care. Support why a more complete or accurate diagnosis or procedure is sought. Support why a diagnosis requires additional clinical support to be reportable. Avoid the qualifier possible in the formation of the query question. Avoid queries that fail to include clinical indicators that justify the query or justify the choice provided within a multiple choice format. Engage the provider to indicate a specific diagnosis or procedure. Role of prior encounters in queries. There has been much discussion and confusion regarding the use of information from prior encounters in a current clinical documentation query. Some major developments require taking another look at this. The field of clinical documentation integrity continues to mature and develop beyond clarifying for reimbursement purpose and is striving for health record integrity. Implementation of the EHR brings information that was once buried in storage and hard to access the fingertips of physicians and querying professionals, leading to a more detailed reference and a richer picture of a patient's history. Recent CMS initiatives such as bundled payments and value-based measures expand the episode of care across settings, transitioning to a patient or disease focus instead of setting of care focus. CMS and many commercial payers regularly aggregate healthcare data across settings on an annual basis. A query may be initiated to clinically validate a diagnosis that a prior health record provided evidence to support, particularly when clarifying specificity or the presence of a condition which is clinically pertinent to the present encounter, supporting accuracy of care provided across the healthcare continuum. Prior encounter information may be referenced in queries for clinical clarification and or validation if it is clinically pertinent to the present encounter. However, it is inappropriate to mine a previous encounter's documentation to generate queries not related to the current encounter. Queries using information from prior encounters may be utilized when relevant in the following situations, but not limited to. Diagnostic criteria allowing for the presence and or further specificity of a currently documented diagnosis. Treatment or clinical criteria or diagnosis relevant to the current encounter that may have been documented in a prior encounter. Determine the prior patient baseline, allowing for comparison to the current presentation. Establish a cause and effect relationship. Determine the etiology when only signs and symptoms or treatment are documented. Verify POA indicator status. Clarify a prior history of a disease that is no longer present. Hope I'm good so far. Excuse me. When consider Thank you. When considering whether a query could be issued using information in the prior record, carefully consider the general rules for other additional diagnosis that states for reporting purpose, the definition of other diagnosis is interpreted as additional conditions that affect patient care in terms of requiring clinical evaluation or therapeutic treatment or diagnostic procedures or extended length of hospital stay or increased nursing care under monitoring according to ICD 10 CM official guidelines. It would be inappropriate to query for a diagnosis that, if documented, would not satisfy this criteria. A query cannot be based solely on the information from a prior encounter. There must be relevant information within the current encounter to substantiate the query. Clinical indicators. This is a broad term encompassing documentation that supports a diagnosis as reportable and or establishes the presence of a condition. Examples of clinical indicators include provider observations, physical exam and assessment, diagnostic findings, treatments, etc., provided by providers and ancillary professionals. There is not a required number of clinical indicators that must accompany a query because what is a relevant clinical indicator will vary by diagnosis, patient, and clinical scenario. The purpose or type of query will also impact how much clinical support is necessary to justify the query and, when applicable, reasonable options. When the purpose of the query is to add a diagnosis, clinical indicators should clearly support the condition, allowing the provider to identify the most appropriate medical condition or procedure. The quality of clinical indicators, how well they relate to the condition being clarified, is more important than the quantity of clinical indicators. It can be identified from sources within the entirety of the patient's health record, including emergency service, diagnostic findings, and provider impression, as well as relevant to prior visits. If the documentation is clinically pertinent to the present encounter. For example, there is care being provided in the current encounter that necessitated the review of a previous encounter to identify the undocumented condition. Complaint query practice always requires the individualization of each query to reflect the specifics of the current circumstance. So who is queried? Healthcare data is obtained primarily from diagnosis and procedure codes. In particular, diagnosis codes are only assigned based on the documentation of those licensed independent providers who render direct patient care. Code assignment may be based on other physicians, that is, consultants, residents, anesthesiologists, etc. So documentation if there is no conflicting information from the attending physician. When conflicting documentation is present, it is the attending physician who should be queried to resolve the discrepancy. There are occurrences for which queries are applied to individuals who are not classified as a provider. So the AHA Code Clinic states it is appropriate to assign the procedure code based on documentation by a non-physician professional when that professional provides the service. For example, infusions may be carried out by a nurse, wound care provided by a nurse or physical therapist, mechanical ventilation may be provided by a respiratory therapist, or a medication may be ordered by the physician and administered by a nurse. In these instances, clarification may be needed from a non-physician professional and queries should be assigned as appropriate. All individuals who are like to receive a query should be educated about the reason for the query, the process, and the expectations for completion and documentation. How to query? Verbal, written paper, and electronic queries serve the purpose of supporting clear and consistent documentation of diagnosis being monitored and or treated during a patient's healthcare encounter. Regardless of the method, a query must adhere to complaint, non-leading standards, permitting the provider of record to unbiasedly respond with a specific diagnosis or procedure. Reference to a reimbursement must not occur. All relevant diagnoses, lab findings, diagnostic studies, procedure, etc., which illuminate the need of a query should be noted. Regardless of the format and technology used, a query should not direct the provider to document a specific response. Best practice dictates that whenever possible, query response be consistently documented within the health record as part of the progress note and a discharge summary or as an addendum as appropriate. If a complaint query has been properly answered and authenticated by a responsible provider, the part of the code assignment. Example for non-leading standards. Query raised. So these examples are from my day-to-day coding process where I was involved in the to lead the team of query process team. So it was a very interesting time where we had a proper communication from the provider end and the internal team, and it was a time period where this query process transition got a very well into a established process. So just felt happy to share with you on this moment. Query raised for DOS 03/28/2022. The patient presents for an annual physical exam documented in HPA. However, we are missing confirmation of the adult annual examination, the Z code. Diagnosis in the assessment and plan. Kindly update the same in the provider documentation and amend the same to proceed further with coding. So the provider response. So do I need to add Z00.00 to the assessment and plan? Is there anything else I need to do? Non-reading query response. For DOS mentioned above, please amend the documentation with appropriate diagnosis to code annual wellness visit. Thank you. You got it right? Example for inappropriate queries. Missing required documentation. A review of the chart for date of service 5/4/2022 indicates the provider performed Kenalog 40 mg. However, documentation does not meet the regulatory requirements for coding. Please update the chart with the site to support the billing for this service. Once updated, please respond with an addendum note and send back to the medical coding service. So here the response from the QC. Okay, since we are in the process of streamlining the process, it is the QC is not only for the coding process but also for the query process. So documents support the route of administration of injection and per 2022. In reviewing the patient's chart, we have identified the following conflicting information. As per 2021 ENM guidelines, documentation supports for 99214 moderate. However, notes from practice states see discussion notes level 5 99215. Please confirm whether we have to follow practice notes or documentation for labeling the service. In order for us to code accurately, please resolve the discrepancy. So the internal response coding guidelines suggest to code as per the medical record and the documentation. The CDA professional can be involved in providing education to the provider in documentation improvements. Verbal queries. When verbal queries are utilized, they should be memorialized to include documentation of the conversations that occur with the providers regarding documentation of reportable conditions or procedures. Conversation should be non-leading, include all appropriate clinical indicators and all plausible options. In capturing the essence of the verbal discussion, timely notation of the reason for query, date or time and signature, clinical indicators, and options provided should be recorded and tracked in the same manner as written queries and be discoverable to other departments and external agencies. Examples of verbal query documentation. The documentation of verbal queries should follow a standard format to include all necessary information. Spoke with Dr. X regarding the documentation of the condition or the procedure based upon the clinical indicators found in the health record. List what was found and where. Written queries. Written paper and electronic queries ought to be constructed in a clear and concise manner, citing relevant clinical indicators and identify applicable diagnoses that are fundamental for the provider to accurately respond. Queries should be legible and grammatically correct. All clinically supported options should be included as well as additional options that permit the provider to craft their own alternate response. Options may include other, unknown, and unable to determine, not clinically significant, integral to, or other similar wordings. Written queries can have the following format: open-ended. The provider free takes a response which may or may not align with documentation needed to support code assignment. Example, a patient is admitted with a pneumonia. The admitting HNP examination reveals WBC of 14,000, a respiratory rate of 24, a temperature of 1 or 2 degrees, heart rate of 120, hypotension, and altered mental status. The patient is admitted an IV antibiotic and IV fluid resuscitation. Leading, the patient has elevated WBC tachycardia and is given an antibiotic for Pseudomonas cultured from the blood. Are you treating for sepsis? So the question will end like yes or no, right? Non-leading question should be, I'm sorry, based on your clinical judgment, you can provide a diagnosis that represents the below listed clinical indicators. In this patient, admitted with a pneumonia, the admitting history and physical examination reveals the following. Please document the condition and the causative organism in the medical record. Okay, you understand, right? So in this query, the coder is questioning, are you treating for sepsis? So this is a leading query which is not appropriate. So This is the takeaway from this example. A patient is admitted for a right hip fracture. The HNP notes that the patient has a history of chronic congestive heart failure. A recent echocardiogram showed left ventricular ejection fraction of 25%. The patient's home medication include metoprolol XL, lisinopril, and Lasix. So the leading query is, please document if you agree the patient has chronic diabetes. So if we ask like this, what the provider will say, agree or disagree. So the option is very limited, right? So we should avoid the leading query. And the non-leading query will be like, it is noted in the impression of the HNP and the patient has chronic congestive heart failure, and the recent echograph noted the cardiac review reveals ejection fraction of 25%. Can the chronic heart failure be further specified as chronic systolic heart failure, chronic diastolic heart failure, chronic systolic and diagnostic heart failure, some other type of heart failure undetermined? So this is more professional and standard, right? Yes or no queries. Yes or no queries should only be employed to clarify documented diagnosis that need further specification. Yes or no queries may not be used in circumstances where only clinical indicators of a condition are present and the condition or diagnosis has not yet been documented in the health record. The query should include the documentation in question with the relevant clinical indicators and be constructed so that it can be answered with a yes or no response. Below are some examples when a yes or no query may be applicable. Determining POA status. Substanding a diagnosis that is already present in a health record with interpretation by a physician. Establishing or negating a cause and effect relationship between documented conditions such as manifestation, etiology, complications, and conditions or diagnostic findings. Resolving conflicting documentation from multiple providers. Example for SR no queries. The clinical scenario. A patient is admitted with cellulitis around a recent operative wound site, and only cellulitis is documented without any relationship to the recent surgical procedure. The query, is the cellulitis due to or the result of the surgical procedure? Please document your response in the health record or below. So here the options given were yes, no, other, clinically undetermined, name and date. The rationale. This is an example of a yes or no query involving a documented condition potentially resulting from a procedure. Congestive heart failure is documented in the final discharge statement in a patient who is noted to have an echocardiographic interpretation of systolic dysfunction and is maintained on lisinopril, Lasix, and lanoxin. The query, based on the echocardiographic interpretation of systolic dysfunction, in this patient maintained on lisinopril, Lasix, and lanoxin, can your documentation of congestive heart failure be further specified as systolic congestive heart failure? Please document your response in the health record below. You understand, right? This SRN query provides an example of determining the specificity of a condition that is documented as an interpretation of an echocardiogram. The another example, during the removal of an abdominal mass, the surgeon documents in the description of the operative procedure a serosal injury to the stomach was repaired with interrupted sutures. In the description of the operative procedure, a serosal injury to the stomach was noted and repaired with interrupted sutures. Was this serosal injury and repair a complication of the procedure, integral to the above procedure, not clinically significant, other, clinically undetermined? Please document your response in the health record or below, accompanied by clinical substantiation. The rationale: this is an example of a query necessary to determine the clinical significance of a condition resulting from a procedure. General written queries. So, am I good so far, or am I going fast? Do I need to slow down my pace? Kindly provide me an update. Am I good? Okay, I take the response positive and taking it forward. A provider's response to a query should be documented in the health record, even if the patient has been discharged. If the record has been completed, then an addendum should be created and authenticated according to the organizational policy. As noted in AHIMA's toolkit, amendments in the electronic health record, the addendum should be timely bear the current date, time, and reason for the additional information being added to the health record and be electronically signed. While organizations are free to determine the specific of their query process, complaint practice requires that all queries either be a permanent part of the record or be retrievable in the business record. Query practice should be managed and monitored for complaints to organizational policy. Organizations should develop pertinent query policies, including a query retention policy and escalation policy. Query retention policy. It is recommended that the policies specify the completed query be a permanent part of the health record and the location. If it is not considered a permanent part of the health record, it should be considered as part of the business record and retained for auditing, monitoring, and compliance. If the query is deemed to be part of the health record, it will be subject to health record retention guidelines, which vary from state to state. Example, query retention. Queries will be maintained in a business folder of the health record for a period of 7 years or as stated by medical laws. Provider response should not impact the decisions regarding retention of the query. Facilities escalation policy. Facilities must develop an escalation policy for unanswered queries and address any medical staff concern regarding queries. If a query does not receive an appropriate professional response, the case should be referred for further review in accordance with the facilities return escalation policy. Escalation may begin with the supervisor or manager and should efficiently move up until resolved. The escalation process may include, but is not limited to, referral to a physician advisor, the chief medical officer, or other administrative personnel. The escalation process is not meant to direct or intimate a recipient for a specific or particular response. This policy should clearly outline expectations of each individual involved in the process, including the expected time frames in which resolution or further escalation is expected. The best practices. Healthcare professionals who work alongside practitioners to ensure accuracy in the health record documentation should follow established facility and organization process, policies, and procedure that are concurrent with recognized professional guidelines. Non-complaint. Example 1. On admission, bilateral lower extremity edema is noted. However, there are no other clinical indicators to support malnutrition. Do you agree that the patient's bilateral lower extremity edema is diagnostic of malnutrition? Please document your response in the health record below. The rationale here is malnutrition is not a further specification of the isolated finding of a bilateral lower extremity edema. An open-ended or multiple choice query should be used under this circumstance to ascertain the underlying cause of the patient's edema. Case study 2. Non-complaint query. A patient is admitted with an acute gastrointestinal bleed and the hemoglobin drops from 12 to 7.5 and 2 units of packed red blood cells are transfused. The physician documents anemia in the final discharge statement. In this patient admitted with the query follows as in this patient admitted with GI bleed and who underwent a blood transfusion after a drop in the hemoglobin, can your documentation of anemia be further specified as an acute blood loss anemia? Please document your response in the health record. In this example, a yes or no query is not appropriate for specifying the type of anemia. A multiple choice or open-ended query is a better option. Do you with me? Non-compliant example 3. In the ED, a Foley catheter was inserted for the patient with a dysuria and elevated WBC. That catheter associated urinary tract infection and this was coded. Quality has requested review of the HCC condition to ensure it should be coded as it does not meet the CDC definition for CAUTI. The query here is the quality department has indicated that your documented diagnosis of CAUTI does not meet the CDC definition, which impacts the hospital acquired conditions statistics for your profile as well as the hospital. Does your patient have a catheter associated urinary tract infection? The rationale here is this query is inappropriate as it explains the impact of the addition or removal of the diagnosis for the physician and hospital profiles. This query questions the physician's clinical judgment, which may be more appropriate in an escalation policy and or physician education regarding the CDC definition of CAUTI. So the above references are taken from the links here. Any questions, team? Because I couldn't see your questions or anything, so I will stop sharing to see any questions from your end in the chat box. Okay, so I welcome if there is any questions from your end to email to the APC local chapter officer Abu Dhabi. So I will get the questions from them to answer you appropriately. Thank you very much for your patience. And yeah, I will give it to our officer, Sheikh. Thank you.